women having they've got complex situations?
Yeah, so the whole country now is divided into maternal medicine networks, and each network, so Yorkshire and Humber are a network, each network has maternal medicine centre, so that Sheffield and Leeds are a combined one, and you should have an obstetric physician or a medical doctor working with the obstetricians in each centre to look after women who have medical problems in pregnancy. And the aim is to keep care locally as much as possible, but there are some people we would recommend delivery in one of our centres. Okay, so I'm on my next slide now, so that's great. So I think the main aim of what I'd like to get across today is that the majority of women with diabetes have a healthy pregnancy and have a healthy baby. And I think there's lots of things out there, and there's lots of, when people go to appointments, they're told lots of scary things about diabetes pregnancy, but the bulk of the people we see have a healthy pregnancy and a healthy baby. But what's really important is planning that pregnancy, because the outcomes are better and people do better in pregnancy if they go in with their health optimized, so being prepared for pregnancy. So I'm going to talk about what things might be discussed or might be done to prepare for a pregnancy, and then what to expect when you go to a diabetes antenatal clinic, and then I'm going to hand over to Carly for the rest of the evening. I'm still struggling with maths. This is just there to remind me that pregnancy, and to say and acknowledge that pregnancy is really an emotive subject. And people are often on different paths and different places in their fertility journey. And I think anyone who works in pregnancy understands that and can empathise with that. And it's okay to feel upset, and part of it is kind of acknowledging. And so it's just a kind of warning, and just to acknowledge that. So just for the sake of this talk, I'm talking about diabetes, mainly type 1 diabetes, type 2 diabetes, and then we talk about gestational diabetes. There are other types of diabetes, and we see those people in pregnancy, and I'm happy to talk about those or ask if there are any questions, but for this talk, I'm mainly focusing on these types. And I'm sure I don't have to explain to anyone kind of the differences, but just for kind of completeness, type 1 diabetes is that lack of insulin and is treated with insulin replacement. Type 2 diabetes is there's not enough insulin for the glucose to be regulated, often managed with medication rather than just insulin. And then gestational diabetes is a condition in pregnancy that resolves afterwards. And pregnancy is challenging to manage when you have diabetes because of what happens to the way you handle insulin or the way you respond to insulin. So if you look at this graph, it's difficult because I can't point to it, but if you go into a pregnancy with a certain level of insulin resistance, in that first 3 months of pregnancy, that resistance will reduce. So you become more sensitive to insulin in the first 12 weeks of pregnancy. So if you've got type 1 diabetes or type 2 diabetes and you're on insulin, you generally need less insulin gradually over that first 12 weeks of pregnancy. And at around 12 to 16 weeks of pregnancy, that's when you generally tend to be most sensitive to insulin. And if you are on insulin, that's the time when hypoglycemia or low blood sugars tend to be the biggest concern. And often people will lose their awareness or symptoms of hypoglycemia around that time. And then as pregnancy then progresses, what you get is really a general, gradual, massive increase in insulin resistance as time goes on. And when we're kind of treating people with insulin in pregnancy, every week we're changing those doses, or changing your carb ratios, or changing kind of medication that you're on. And that's why it's so challenging, because week on week it changes. And so it's really intense and challenging and difficult. And I would say it's a really carbohydrate intolerant sort of state. So you just can't tolerate very much carbohydrate. So Carly will talk more about that. As soon as your baby is delivered and the placenta is delivered, you are super, super sensitive to insulin again. So, and the changes in insulin amount. So if you've got type 1 diabetes and maybe you're on a 1 unit for 10 grams of carbohydrate ratio at the beginning of your pregnancy, you might be on a 5 units for 10 grams of carbohydrate by the end of it. And then as soon as the baby's born and the placenta's kind of delivered, you're more sensitive than you were at the beginning of your pregnancy and need less insulin. So that's the challenge, and it's kind of having to constantly change things. And the reason that people develop gestational diabetes is because that's when people can't make that extra insulin to get over the resistance. And so you kind of develop diabetes, or what we define diabetes, in pregnancy, but as soon as your baby's delivered, then you don't have diabetes anymore. But it does mean you're increased risk of getting type 2 diabetes following this. So there's always a lot of emphasis on what the risks are in pregnancy when you've got diabetes. And it's hard because I feel like sometimes it's almost used as a threat or as a kind of to scare people into managing their diabetes before pregnancy. The majority of the risks we see in people who don't have diabetes. It's just that in diabetes, they're at an increased risk, but there's lots that we can do to navigate and reduce those risks down. And I kind of think about it in the risks of what are the risks to the mum, and then what are the risks to the baby. In the risk to mum, the main risk we worry about is preeclampsia. So that's a blood pressure condition in pregnancy. It's caused by the placenta, and it can cause lots of different effects to different parts of the body. And that's a condition that, you know, there's lots of patient groups that are at risk for preeclampsia, and it's something that you kind of keep a really close eye on in pregnancy. Talked about hypoglycemia that you sometimes get kind of at the end of the first trimester, and that loss of symptomatic awareness. And then if you have eye disease or kidney disease going into pregnancy, that can sometimes get worse in pregnancy. Generally stays stable for the majority of people, but it's something, again, we just tend to monitor more carefully. When there is to the baby, which is generally what mums focus on, is there is an increased risk of miscarriage, and there's an increased risk of problems with the baby's heart and spine development. Actually, if we can reduce HbA1c to under 48, which is often a challenge, but if we can, then actually those risks fall to the background population who don't have diabetes. And every little improvement in HbA1c reduces those risks. So that's why we talk about preparation for diabetes and pregnancy. And that's why we put such an importance and kind of place importance on that. If you put into Google diabetes and pregnancy, what you're going to get is a picture of a large baby and a little baby, because generally that's the kind of main complication that people used to see, is that you used to get a big baby. And the reason it happens is that if you've got extra sugar going around mum's blood, that sugar goes straight across the placenta, and the baby does not have diabetes, so the baby produces extra insulin, and then that sugar then is converted by the insulin to fat, and so you get a larger baby. And the concern about that is that that baby needs to be delivered, so you can have birth injuries or you know, really long labours and things. So that's why we get concerned about them, and there are measures we put in to try and to observe that. You can get small babies as well, and I think that's something we see more in type 2 diabetes, that if the placenta isn't formed as well as it should be, and you see that in kind of type 2 diabetes, that you can have smaller babies because the nutrients aren't getting through the placenta. So you can get either. The one that kind of we worry about the most, and that kind of causes us most concern, is the risk of stillbirth. And that is still significantly higher than people who don't have diabetes, but the risk is still small. And there are the things we put in place are that we recommend an earlier delivery. So we say that we recommend most people who have diabetes to deliver between 37 and 38 weeks if they've got type 1 or type 2 diabetes. And that's what we're scanning for and things like that. So there is a lot of work being put into trying reducing that risk, and I'll talk about some of those things as we go on. So this is the main point I really want to get across this evening, that sometimes if you've had type 1 diabetes, particularly for a long amount of time, and then you're trying to prepare for pregnancy, the idea or the thought of trying to get HbA1c's under 48 can be really difficult and can make you really anxious. But what I would say to you is that any reduction in HbA1c will be beneficial and will kind of have an impact. We have lots of data about diabetes and pregnancy now. So the National Pregnancy and Diabetes Audit has been running for, I think, about 10 years now. So every pregnancy for someone with diabetes, we record certain things. So we'll record whether the person was on folic acid, what medications they were on, what the HbA1c were going into pregnancy, and then what the outcomes were. So was it how the baby was born, how many weeks they were, and you know, whether the baby went to special care. So this is kind of, the reason we're collecting the data is to monitor how we are doing. So we're monitoring the service that we're providing. This is not a kind of monitoring of individuals. It's just looking across the country. How are we doing? How are we preparing people for pregnancy? Are we managing to reduce the poor outcomes or not? Are we doing everything that we should be? And unfortunately, we aren't. So I would say, well, the data shows that 7 out of 8 women who come into pregnancy who have diabetes are not well prepared for pregnancy. And when I say not well prepared, what I mean is they're not meeting their HbA1c target, that there are medications that are not safe in pregnancy, and they're not on the right dose of folic acid. And that's, I feel, the responsibility, and it's a joint responsibility, but I think the main issue is that we're not getting the information, we're not telling people, we're not letting people know that these things are important. And I think if you've got type 1 diabetes and you're in secondary care, you're more likely to get the right information. But my main worry and concern is the people who are in the community and under primary care who might not be accessing that information as much as they need to. And this is a really, really nicely written of this. So this was kind of what we would call qualitative data. So not numbers, but about kind of asking people who have diabetes and asking healthcare professionals who are looking after people with diabetes, what are their thoughts about diabetes and pregnancy? And this was about type 2 diabetes and pregnancy. And it was majority of people, it was asked about primary care. So this is not secondary care doctors who are working in diabetes all the time. This is primary care doctors and nurses and women who have type 2 diabetes. And really sadly, what it shows is that people feel really negative about type 2 diabetes and pregnancy. And that's both healthcare professionals and people with diabetes. And I think the reason is that the systems aren't there to help people, are not there to help young women with type 2 diabetes. You know, I feel that, and I don't want to get shot, but I feel that kind of a lot of the processes and the pathways that are set up for people with type 2 diabetes are set up for men who are older, and we are not really providing the care and the information for people who are younger, who are female, who have got type 2 diabetes and who want to get pregnant. So when I'm talking to people about planning pregnancy, the first thing I talk about is contraception. And essentially, there is no difference in what contraception is available for people with diabetes and what contraception is available for people who don't have diabetes. And I think that we need to start getting that information out there. And if there are some restrictions in regards to, you know, if you've got an elevated BMI, you might not be able to use them, but in regards to just diabetes, there's no restrictions. And when we're planning pregnancy, we usually say it takes about 6 to 12 months to plan for pregnancy if you've got diabetes, and therefore you really need some good contraception in place. And there are pros and cons of each contraception, but really what you want is a really good, reliable type of contraception where you kind of prepare and get yourself in the best place that you can for pregnancy. Everywhere has some sort of service like this. So this is Sheffield's sexual health website, and there is so much information on there. It's brilliant, and you can just book yourself in an appointment there. And there are clinics for younger people who are under 18, and there's lots of information, there's lots of leaflets, there's videos, all sorts of resources on the website. So whether you are a healthcare professional who needs to update, or whether you are someone who wants some information, this is a really, really good resource, and I would use it, you know, kind of just to show people some information. So the next thing I'm thinking about often is about blood glucose levels, because that's a lot of what we do in the clinic. You know, we're looking at what blood glucose levels are, what we should be aiming for, and how we do that. So targets for pregnancy, preparing for pregnancy, we are aiming for under 40, HbA1c under 48. Now, that might not be achievable, but that's what we aim for to start off with. And that's what, but it may be that we kind of go, we're starting off with HbA1c of 65, so where are we going to get to? And we might do it like that. Or we might say for some people, actually, we don't think we're going to get to 48, so therefore we're going to aim for under 56. So it's individualized, but generally, that's the kind of target that we're aiming for, and we aim high. If you're testing blood glucose levels, in regards to preparing for pregnancy, we kind of usually say pre-meal targets around 4 to 8. The pregnancy targets are much tighter. So before meals in pregnancy, we're aiming for under 5.3, and after 1 hour after meals, it's under 7.8. So they're really tight, but we don't do that pre-pregnancy because it's potentially too long a time to maintain, and we don't really need to. But that's the sort of target that we're looking for. And different people might monitor their glucose differently. So the NICE guidance, and I think says that, so for people with type 1 diabetes, I'd expect them to be on continuous glucose monitoring. For people with type 2 diabetes, you don't have access to that generally. There are some GP surgeries are currently, you know, kind of offering sometimes the 2 weeks as a way of kind of a sort of educational way of looking at the way you personally might react to certain foods. I think that's really helpful. But there's definitely, you should have access to monthly HbA1cs and blood glucose monitoring, which you don't always if you're not preparing for pregnancy. But the NICE guidance says that, and people should have access to that. It might not be something that you want to do all the time, and it varies depending on where you are in the journey of preparing for pregnancy. But this is the sort of thing that we kind of do offer. And I think, you know, we talk about HbA1c. Yeah, go on, sorry.
I'm just thinking what might be picked online or even here don't actually know what HbA1c is.
Okay, so we use HbA1c as a measure of what your average glucose might be over the last 2 to 3 months. And on the whole, generally, we wouldn't test it more than every 3 months. But when you're preparing for pregnancy and you're trying to get into a really tight target, we often do it monthly because it's helpful to see you going in the right direction. And you should have access to that. And it is in the NICE guidance if anyone's having problems getting access to it. The next thing I kind of think about is medications. And I think about what medications are safe in pregnancy, and what medications we might need to change. So metformin is fine, insulin is fine. A lot of the other medications that people are on for pregnancy are not safe. Okay, and so your SGLT2 inhibitors, so your dapagliflozin, empagliflozin, they're not licensed and safe in pregnancy. Any of your GLP-1 medications, so your Mounjaro, Ozempic, they are not licensed and not safe in pregnancy. We used to use sulfonylureas, so glibenclamide and glycoside, but we don't use those anymore. We might, for very specific cases at certain points in the pregnancy, but generally as a whole, we don't use them. ACE inhibitors, so your ramipril, enalapril, lisinopril, they're also not safe in pregnancy, and neither are statins. So this is really important about getting advice about medications changing, how long you need to be off them for. As a general rule, we usually kind of talk about a 3-month washout period, but it's not always the way. But if you're planning pregnancy, we want people off all of these medications before they get pregnant. And so you can't really do that on your own. You do need to see someone because you may well need an alternative, particularly if you're using an ACE inhibitor for blood pressure management. So that's why it's really important about kind of seeing someone and planning pregnancy. These are the 2 things that we recommend people take when they're planning pregnancy and during pregnancy. So folic acid, that everyone should be on folic acid if they're preparing for pregnancy. The dose is different if you have diabetes. So a lot of people use brands like Pregnacare, but actually that's not enough folic acid. So you can only get it on prescription. So you have to get it from either secondary care or from primary care on prescription. It's 5 milligrams. So it's a different dose completely. And vitamin D, everyone should be on vitamin D if you're preparing for pregnancy. Everyone should be on vitamin D generally. Now I can't think of a group that shouldn't be. And so the pregnancy is no different. So vitamin D you can get over the counter, and most kind of people will just buy their own. And if you do use a pregnant care sort of, or a multivitamin for pregnancy, vitamin D will be in there, but the folic acid is different, and you can only get that on prescription. So that's really important.
Do we get folic acid from bread and other?
Yeah, nowhere near enough.
Just taking
Yes, yeah. So it's definitely much, you know, that even the, so in outside of diabetes, and there's a few other medical conditions that you might have a big dose of folic acid, it's 400 micrograms. There's a huge difference in what we recommend for people with diabetes. So you can only get it on prescription. And don't let anyone tell you that you shouldn't be having it on prescription. Just to show you how we're not doing very well in this. So this is the folic acid uptake. So this is when people walk through the door of an antenatal clinic. Are they on the right dose of folic acid or not? Okay, so the table shows that for people who have type 1 diabetes in our region, when they walk through an antenatal clinic, for people with type 1 diabetes, we have about 45% of people on the right dose of folic acid. So they're coming on the right dose if they've got type 1 diabetes. And some people will tell me the data says is that 50% of pregnancies are planned. So if that is true, which I don't really believe, I think people are better at planning than that. But if I believe that data, then actually we're having 50%, almost 50% of people who are planning pregnancy on the right dose of folic acid. But look at the data for type 2 diabetes. So for people with type 2 diabetes, we're getting up to the dizzy heights of 25%. And that's just about information, about not getting that information out there. You can see on the last column, we've got our kind of data for England. So we are doing slightly better, but it's still appalling. I did one time, Barnsley got up to about 60% uptake, and I was so excited. And I phoned up, there's a really amazing midwife out there called Kirsty, and I phoned up and I said, how have you done this? And she said, don't get excited. It's just that we've just had a lot of people in that last year who've had a pregnancy before, so they knew. So it does waver, it does go up and down. But I still think this is nowhere near good enough. So I kind of mentioned in the slide about the risks in pregnancy, about kind of if you've got complications of diabetes like eye disease or kidney disease, that they can get worse in pregnancy. And we know that eye disease is treatable. And so what we try and get people to do is make sure they've had screening for their eyes before they get pregnant, and if they need any treatment, to have that done before they get pregnant. And because then generally we don't run into difficulties. We look at eyes really closely in pregnancy, so every 3 months they'll be checked in pregnancy. And if they need any treatment, it can be done in pregnancy. There's no problem with that. Ideally, it would be good to have it done before pregnancy, but you know, if things develop, we can treat it. But the important thing is going to get screened, because we can't treat anything if you're not screened. So kind of the other thing we look at is kidney complications, and about whether we need to do anything to optimize kidney function, or do you need to see a kidney doctor before you have a baby? And so we look at urine and we look at blood tests. But blood pressure management is really key to that. So I think as part of when I talk to people about preparing for pregnancy with diabetes, I also look at blood pressure, because it's really important that blood pressure is well managed in pregnancy, and that's everyone. It's just that, you know, if someone comes to see me about diabetes in pregnancy, I'm not going to ignore their blood pressure. I'm going to look at that. And then it shouldn't really be the last thing, but it's kind of how I generally end my consultations about pregnancy counselling, and that when you have a pregnancy and a labour and deliver a baby, it is the most physically demanding thing as a woman you're ever going to do. It is like running a marathon for over 9 months. It's huge, and so you have to get your body in the best condition it possibly can be in to do that. And that's not just in diabetes, that's in everyone. So and it's about, what do you need to do? What are the things that you can do to optimize your health? So stopping smoking, reducing alcohol, looking at what you're eating. Are you getting what you need nutritionally? And I'm going to leave all of that to Carly, really. But it's about kind of just making sure that you're providing the right nourishment for you. You're growing a baby, you're growing another person, so you really need to be in the best condition you can be in. And that's different for different people, but I really like people to try and get active and keep them and maintain it throughout pregnancy if they can. But I don't mean that I'm expecting people to be at the gym. It depends on what you're interested in. It depends on what your baseline is. So, you know, if someone said to me, I've gone from not doing anything to I'm walking, 20 minutes a day, that's amazing, I'm happy. So it's just about what do you enjoy, and it's also really good for kind of mental health and mental well-being as well. And if someone comes into pregnancy and they are swimming 3 times a week, or they're running, or they're walking, or we really encourage people to continue that throughout their pregnancy. So whatever you're going into pregnancy is what we kind of expect you to try and maintain. So it's good to get into good habits beforehand. There are kind of things that can help. So if you are wanting to try and lose weight before getting pregnant, there are some interventions that we can help with or to look at. And it's just about whether that's the right thing for you. But really, we want people to kind of look at what they're eating and what is nutritionally right for them. And then I guess what do you do if you have a positive pregnancy? Contact us directly and we'll get you in and see you quite quickly. But the aim is that if you've got diabetes and as soon as you have a positive pregnancy test, you can tell your partner, you can tell your mum, that's fine, we want to be next. So, I allow a couple, but generally we want to be the first people to know. And we book you into our clinic really early. So if you let us know that you're pregnant, you can expect to hear from us generally within 2 working days. And we'll be in contact with you just to kind of see what you need, to make sure you're on the right dose of folic acid, etc., etc. We see you in our clinic, in our joint antenatal clinic, around about 7 weeks for an early scan. And then we see you then again. But, if you go to your GP and then they push you to a midwife and then they write us a letter, that's going to go on. So you just want to get in touch with someone in diabetes. So however you do that, it doesn't really matter. And if you phone up our Northern General kind of diabetes centre and say, I've got diabetes and I'm pregnant, we will know, we'll get that message. So what to expect in pregnancy? It's a really intense period of time anyway. So anyone who's pregnant, it's a big thing. It makes you anxious, it makes you nervous, it makes you feel really sick sometimes, really tired. And diabetes kind of exacerbates some of those things. It's really, really hard work because of that change in insulin resistance constantly. It's really a hard battle sometimes, but we are here to help, and every hospital will have a team who is there to help people who've got diabetes in pregnancy. And that team should consist of midwives, obstetricians, a diabetes consultant, diabetes dietitian, diabetes nurses, and we work really interchangeable roles, and we kind of are there to help and support. And most people will have contact from the team every 1 to 2 weeks in pregnancy. And that is because of things like continuous glucose monitoring. A lot of that can be done over the phone, but there is a real benefit from seeing people face to face as well. It's tough, and there are times when you will want to throw the blood glucose meter at us, and we get that, and that's why it's useful to come and see us. But that's what we'd expect. You are seen, as I say, for that early scan around 7 to 8 weeks, and then you will have a minimum of 12-week scan, which people without diabetes would have, 20-week scan. And then for diabetes, we have growth scans from 28 weeks as a minimum. So 28 weeks, usually 32, 36. And there's lots of people that have growth scans, but we do get those in diabetes, and we can do them more frequently if we need to. And at that point, we're looking at, what's the size of the baby, how's the baby growing, and we're making judgments and decisions and making kind of changes to make sure that your baby is doing as well as it can while looking after you at the same time. We use aspirin, or we offer aspirin for everyone who has diabetes to try and reduce the risk of preeclampsia. So aspirin it's amazing because it's just this tiny thing that's really available, really cheap, but it actually reduces the risk of early preeclampsia by about 60%. So preeclampsia is a really fascinating variable condition, but if you develop preeclampsia at 36 weeks of pregnancy, so nearly at the end of pregnancy, you deliver the baby. That's what we do, because delivering the baby cures the condition. But if you develop preeclampsia at 25 weeks of pregnancy, we've got a problem, because the mum can get really sick with preeclampsia, and so we would want to deliver the baby for mum's health, but I don't want to deliver a baby at 25 weeks because that baby's going to be really poorly. So then we're trying to marry those risks up. Which is the riskiest bit? Who do we need to protect the most? And aspirin reduces the risk of that early preeclampsia, so the preeclampsia that kind of occurs earlier, and it's 60%. So it's amazing that we've got that little thing that, and you have to take it. It's better if you take it at night, but we want it on board before 16 weeks of pregnancy, so it works. And I said, we offer delivery around about, written 37 to 28, but actually is meant to be 37 to 38 weeks. Yeah. So for most people with, and this is people who have pre-existing diabetes, so not gestational diabetes, we offer, it's usually around about 37 and a half weeks.
It's preeclampsia.
Yeah, so it's a sorry, I should have explained. It's a condition that's caused by the placenta, and the most common things it causes are high blood pressure and protein in the urine, and people get swollen. Actually, it can cause a problem with any organ in the body. So it can make your liver poorly, it can make your kidneys go off, it can make you have kind of fits and seizures if it's not treated. So it's a really dangerous condition that only happens in pregnancy or just after pregnancy. And when everything, if I look at antenatal care for women, everything is set up to try and detect preeclampsia. So you can't walk into an antenatal clinic without someone putting dipping a urine. You can't see a midwife or someone, waving a urine dipstick. And that's because one of the first signs is protein in the urine, and checking the blood pressure every time. So condition that affects a lot of people, not just with diabetes, but we know that people with diabetes are at an increased risk. Just some kind of things that are useful to know. So if you have type 1 diabetes, and there was a really, really great study, I'm trying to think what it shows, done, the results came out in about 2017 that showed that if we give people with type 1 diabetes continuous glucose monitoring in pregnancy, they do better. And so it was mandated, I think around about 2023, that all women with type 1 diabetes should be offered continuous glucose monitoring. So that was step one. And the next thing that's happened is the ADAPT trial that showed that if you use a hybrid closed loop system in pregnancy, you do better. So 2 weeks ago, just 2 weeks ago, it was mandated that every woman who is pregnant with type 1 diabetes should be offered a pregnancy-specific hybrid closed-loop system. In reality, there's one system that fits the bill at the moment, and that's the CAM APS system with the Ipsomed pump. And for those who, I don't know how much people know about hybrid closed loops, but essentially what you've got is a glucose monitor that is picking up the glucose. It feeds back to the computer or the algorithm that tells the insulin pump how much insulin to give. And what we've seen is with a pregnancy specific system, we've seen reduction in larger babies, we've seen less weight gain for women. Sort of, if you're giving extra insulin, people gain more weight in pregnancy, so less weight gain, better HbA1cs, and also a better pregnancy, able to work longer in the pregnancy, lower levels of blood pressure. It wasn't really kind of powered for that, but there's been lots of other benefits, not just the glucose numbers. It's now time for type 2 diabetes to get some attention in pregnancy. It's about time. I feel like it's a long time coming. The PROTECT study is running at the moment. So what this is recruiting people who are pregnant with type 2 diabetes, and they are, when they come into the study, they're either randomized to glucose monitoring, as we would do normally, or to continuous glucose monitoring. And the hope is that this will show that we need continuous glucose monitoring for people with type 2 diabetes in pregnancy. But what I'm really interested in is what target should we be hitting. So for people with type 2 diabetes, what we do is we're kind of going, well, for people with type 1 diabetes, this is what we've said. We'll just say the same for people with type 2 diabetes. And I think that's wrong. I think for type 2 diabetes, we probably should be aiming for a lower average glucose and a higher time in the target range that we talk. I'm going to stop there and answer any questions, and then I'll hand over to Carly.
I've got a question online.
Yeah.
Which is African Caribbean people at high risk of diabetes. Correlation, if any, in gestational diabetes.
Yeah, so much higher risk. So it would be one of the reasons that we would, it's one of the kind of indications for screening for gestational diabetes is ethnicity. And it depends where you live about who they screen for gestational diabetes. So in some areas, they screen everyone because majority of people are high risk. Here in Sheffield and Yorkshire and Humber, so it might be your BMI might be an indication, ethnicity, family history of type 2 diabetes, age, if you're over the age of 40. There's a kind of a big long list of who we might offer screening to, but yes, people who are African descent would definitely be offered it.
But what percentage of African Caribbean women access support preparation pregnancy?
So I presume you're talking about people with type 2 diabetes. I don't have that data, but my guess would be not many. And that's across the board with people with type 2 diabetes. One thing I am cheered by is I do a preconception clinic. So I feel very privileged to be able to do it because preconception care is not really funded in the NHS, but we do provide a service at Jessup. So I have about 9 slots a month for people who have any type of diabetes who want to be seen. And the majority of those slots are taken by people with type 2 diabetes now. So that makes me feel cheered that at least we are getting some of these messages out. But it's really difficult to know how many people are accessing. I can tell you that when we've looked at our data locally a couple of years ago, and this was really crude looking at it, kind of going, who has it documented in their notes that they've had preconception discussions, and it was very low for people with type 2 diabetes, but high for people with type 1 diabetes. And that's because if you've got people who we're visible, you're coming through our services, it's one of our tick boxes. It's, I think for people who are not seeing people in secondary care, the messages it's beginning to get out there, but it's not as clear.
So when you go as a type 1 person for your annual review,
yeah,
and the consultant you see,
yeah,
is that a question they always ask?
They should do. They should do. I don't know how. I haven't looked at. I think most people when we have audited it locally, most people have had something, and it may just be, are you on contraception? Tick the box. Are you planning pregnancy? Has anyone just, it only takes a second. And then if the answer is no, I'm not, or I've thought about pregnancy, it just opens that door up. Sometimes I kind of say, this is like a whole other conversation. Let's have it. Let's me phone you, or let's rearrange an appointment. Because if you mention it just at the last 30 seconds and you've got 5 people waiting to see you, it's difficult. I allow a half-hour slot in my clinic per person, and that sometimes isn't long enough for talking about pregnancy.
What happens if somebody doesn't come to pregnancy? They find out they are pregnant. What are the risks and what are the symptoms of being on those medications they should be on? So
we don't know a lot of them because obviously we can't do the trials.
Is it just because the trials have been tested?
So some data we have animal data on, and for ACE inhibitors, we know that the baby's kidney tract, so that kind of tract doesn't always form, but that is actually a second trimester problem. So if someone comes in on, at 4, 5, 6 weeks pregnant on an ACE inhibitor, it's fine, we just stop it. And we do just stop them. I wouldn't panic, because a lot of what, things like the GLP-1s and your kind of SGLT2s, we just don't know. We've got some animal data that perhaps it's not a good idea, but that animal data is always massive doses. And I think, so I wouldn't panic, just stop. We stop them and we just want to see you. So it's fine. You just need to get booked in and we just see you and quickly. There's no, you're not gonna, if you come into our clinics, we're not gonna say, why are you on this? Why haven't you done this? That's not what we're about. We're just about making and helping you be as well as you can in a pregnancy and to look after your baby as best we can. And it's not easy, and we get that. Okay. I'll hand over. Thank you.
Okay. Hello. So my name's Carly. I'm a diabetes dietitian and I work at the hospitals in Sheffield. And I work with Emma in the diabetes antenatal clinic, Jessup Wing Hospital. And today, well, if we look a bit wordy, few things that I thought we could focus on. 1 minute, got a cheat sheet. So some of it's going to echo what Emma's already described. And that was focusing on preparation, but also things that can help during the pregnancy. So we're going to look a little bit more at the glucose targets and the things that can help manage your glucose levels in the pregnancy. Obviously, some of that includes dietary advice. So the main dietary advice today is going to help manage glucose levels in pregnancy, and that helps you get the glucose in the target range. What I will say is, though, if you happen to be watching this and you have diabetes or not, or you've got gestational diabetes, type 1 or type 2, actually the dietary advice that I'm going to describe can help you manage your glucose levels. And away from pregnancy, we sort of describe it as our carb smart approach. So that's good, I thought. And then, yes, there's a lot you could think about. There's a lot that could be done. But we want to try and remain calm, not feel too overwhelmed. So I'm just going to touch on a little bit about, how might I approach this? Where do I want to put my focus? What's going to help me get closer to my goal? And then I've had a good look. There's a hell of a lot of helpful information available. So it's not an exhaustive list, but I have cherry picked some. And there's lots of slides with lots of information. So hopefully we can make that available too. Just waking it up, I think. Yes. So Emma mentioned, didn't she, that planning for pregnancy, well, that's ideal, but a lot of things aren't planned, are they? In an ideal world, we want to be preparing to stop contraception, planning to stop contraception like 6 to 12 months before. And there are things to consider. But as I said, because there is quite a lot we could talk about, I'm not going to talk too much about what can happen leading up to the pregnancy, but I doubt there's any surprises. Cutting down on alcohol, getting help to stop smoking, moving more, I'll come back to that. Eating well, I'll come back to that. And these things can actually help manage body weight as well. Not happy, is it? There we go. So, I mean, eating well at any time has got lots of health benefits, but particularly as you prepare for pregnancy, there are things that can help when you then become pregnant. So it's almost, for some people, it's starting to make changes that can help you during the pregnancy. So that's about maybe eating regular meals and snacks, which can help with regulating your appetite. It can help avoid the swings in glucose. Obviously, it can help prevent nutritional deficiencies. And we're thinking about those habits that can take time to establish. So it's helpful to be thinking about these, preparing and starting to make changes. And obviously these things can influence the baby's development. So just a little bit on supplements. Again, some of it's echoing what Emma's already described. So I appreciate that some women might be watching that are currently pregnant and you might have gestational diabetes. But you can just see there that you've got that difference in the dose, haven't you? Away from type 1 and type 2 diabetes, and that higher dose is only available on prescription. Vitamin D, yes, that's something that's helpful to take because we don't get enough of it in our diet, and particularly in sort of autumn and winter, we can't get enough of it from our exposure to sun on our skin. And then if you think about some people that might cover the skin, then they could be higher risk, or women with a high BMI over 30. So there is a recommendation to take a supplement in pregnancy, and you might take it before. Some women might have heard of the Healthy Start vitamins. That could be free or like a small cost, depending on your circumstances, from over 10 weeks gestation. I've just added what you can see is in there. So you would get enough vitamin D from that, but you wouldn't get enough folic acid. If you follow a plant-based diet, it would be helpful to supplement with a supplement that contains iodine and vitamin B12, because these are lacking, so specific, especially in pregnancy, and you could consider an omega-3 supplement also. Just a little reminder to avoid cod liver oil or supplements containing vitamin A during pregnancy, because these can harm baby. Just if you're pregnant, you would want to avoid. Is that what you mean?
Not.
Yes, yes. So, Emma's touched on glucose targets as you prepare for pregnancy. There's different ways of considering that. Ultimately, what you're aiming for is optimizing your glucose level. You could call it optimal diabetes management. And there's different ways you could consider that, because you could look at your glucose before you eat. You could look at an HbA1c result. And if you're using a finger prick blood glucose meter, you might even just want to look at that single number, like the average. So this chart is just showing you there's different ways you could approach, how can I get a gauge on my glucose levels? What you'll notice is here, it doesn't mention in that pre-pregnancy stage or away from diabetes, looking at your glucose after you eat. There's no target glucose after you eat away from pregnancy. But it is there during pregnancy. So it's like extra information, and it's an extra target to aim for. And it's this one that can be difficult. But actually, what I'm going to describe today is the dietary advice and some other factors that can help allow the glucose to rise more gently after you eat, and it makes it easier to reach the glucose target 1 hour after a meal. And just as Emma described, we've got these targets for really good reasons. But it is something to aim for, and any step that you make that helps you get closer to these targets is really positive and reduces the risks for baby. So for pregnant women that use CGM, so in type 1 diabetes and some women with type 2 diabetes, another way you might be considering, how is my diabetes managed? What might optimal look like? What are the glucose targets? Then you could look at time in range. And you can see in the first column, the target range is 3.9 to 10. And optimal might look like, for some people, because it is individualized, 70% or more of the time. If you look to the right-hand column now for pregnant women, it's still 70% or more of the time, but the target zone's different. It's smaller. It's 3.5 to 7.8.
And like now, my blood is less than 3.9.
Yeah.
I think if it was 3.5, there's a chance that I might losing it.
Yeah, yeah.
And so if a woman was pregnant and had diabetes, their blood sugar was say 3.6. What makes it different in pregnancy that you're okay at that level?
That's a good question. And you might not feel okay at that level. Yeah, but it is the target range in pregnancy and it helps look after baby. So that would be optimal. But it doesn't mean that you're comfortable and feeling well at a 3.6. And actually, you might take some action to boost, like to push some glucose into the blood. It's just that balance. So we talk around when you might take a hypo treatment to treat your hypo. So we'd say a glucose below 3.5. But let's say the glucose was below 4 and you were looking at your CGM and the arrow was down. You're going to eat or drink some type of carbohydrate that will allow it to rise again. So it is one of those things that for some women can feel it's one of those other things that I'm trying to balance. But I guess one of the messages we want to make clear today is there's lots of support around that and lots of tools that can help. But just like in life in general, there's always something we're juggling, isn't there? Okay. So there are some things that will help manage glucose levels in pregnancy. And some of these, I've put some sort of ideas up, haven't I? But and some of them actually might not apply to you. For example, if you're pregnant now with gestational diabetes, you may or may not use insulin to treat your diabetes. And we are moving on to the dietary advice next, but we can think about food. We can think about increasing your awareness and knowledge around carbs, because we know the bigger the amount of carbs, the bigger that rise in glucose will be. Do you eat? And that could be, I might look at a handy measure to help me gauge what a helpful amount of carbs is. Or if you take daily injections of insulin or a pump, you might carb count. So that's putting numbers to carbs and then adjusting your insulin to match it. Activity makes your insulin work better. So we've talked about insulin resistance, whether that's the insulin that your own body makes or that you inject or bolus. Being active makes your insulin work better. These things help keep your glucose in the target range. So any way you can break up periods of sitting or moving your body more. And what we'll see is if we're saying, well, hello, we're going to have a target 1 hour after you eat now in pregnancy, we could actually use activity as one of these tools to help flatten that rise in glucose after you eat. So I think of some of this advice as tools in your belt, and you could like start using those tools before you become pregnant, get really familiar with them, get really good at using them. You might just use one. Maybe when you've really got a good handle on that, you might start using another one. And in the pregnancy, some women will come to those tools at different points. Some women might get going with it all at the same time. And we look at your glucose levels and support you. So if you don't need a tool, well, you don't need a tool, but you might. And it's knowing what those tools are. So it could be that getting the time in that you give an insulin injection or ask for a bolus from your pump is another factor that can help manage your glucose levels. Obviously, getting your carbs right, if you're going to adjust an insulin dose or ask for a bolus, will help you get the right amount of insulin. So that could even be, are my insulin doses right for me? Am I carb counting accurately? It's also a bit about preventing and treating hypos correctly and learning from your experience as usual, really. But I guess that might mean reviewing your glucose after you eat and learning more about how different foods or meals affect your glucose levels. So we are thinking about things that will help reduce the rise in glucose after you eat. That is what we're thinking about.
Holly, could you just say what carb ratio is?
I can. So if you carb count, which is putting numbers to carbs, I'm going to estimate or I'm going to work out or know how much carbohydrate is in the food I'm eating. You can then match that with an insulin dose. And the way you might do that is you'd have an insulin to carbohydrate ratio. And that might look like, for example, every 10 grams of carbs that I'm going to eat in this plate of rice needs a unit. And what that means is the 10 grams of carbs will push some glucose in the blood. And for me, when I give a unit, that glucose that entered the blood from that rice can leave the blood again. So carb counting and using a ratio helps keep your glucose levels in the target range and makes things more predictable and stable. Some people actually take a set amount of insulin, and particularly people that take multiple injections of insulin with type 2 diabetes in pregnancy. Perhaps they only use an insulin in pregnancy, may not learn these skills. They might have a set dose, and that can work as well. But if you think about a set dose, it can only do a set job. So the way we want to try and get things in balance there to help manage glucose levels is you kind of need to be choosing the right amount of carbs. And when you're keeping it steady and similar, you're then hitting a target, aren't you? So it's much easier to find the set dose that works. Versus the carbs is constantly changing and the amount's changing, and we're trying to hit a moving target and with this set dose, it's not going to work out as well. Again, there's lots of support around that. Oh. Now, yes, we've talked about food a little bit. We've talked about activity. We know that managing body weight can help reduce insulin resistance, especially in type 2 diabetes. And insulin resistance, basically, the opposite of that is being more sensitive to insulin, increasing insulin sensitivity. And that means the insulin that you inject or make is working better. And that might mean you get lower glucose levels, or it might mean you're getting the glucose levels you want and you don't need as much help. So perhaps like a smaller dose of insulin. But, you know, away from insulin, we want to increase insulin sensitivity. And this is going to be a tool to help manage glucose levels. But there are other things that influence insulin resistance. So it can be about getting enough sleep, managing stress, staying connected with people, being compassionate. So moving on to the dietary advice, keeping an eye on the time. Top tips for optimizing glucose levels in pregnancy is what we talk about. And if you've got gestational diabetes, we've got a lovely new leaflet, which is nice and bright and colourful. And these things echo each other. You're getting the same information. Maybe some extra detail in the top tips, which is aimed at women who have diabetes type 1 and type 2. So it's all about helping the glucose rise more gently after you eat to help make it easier to get your glucose in the target range 1 hour after eating during pregnancy. And that target is below 7.8. So being active makes your insulin work better. If you're able to move more at any time, great, more the merrier. But can you see how moving after a meal will influence that 1 hour reading? Now, that doesn't mean I'm going to go and do an exercise class, or you don't even have to leave the house. Just 10 to 15 minutes of moving around, that could be housework. I'm doing it after you've eaten, before the 1 hour check. Now, obviously, if you inject insulin or use a pump, it could be a fine balance, because if you are especially active after a meal, you might be active enough to make the insulin work even better and your glucose starts to drift down. Again, there's ways you can moderate that. So the dietary advice, well, we eat lots of different food. It all makes up part of a healthy, balanced diet. But we do have to give more attention if we're thinking about what directly affects glucose to carbohydrates, because this breaks down to glucose in the body, that enters the bloodstream, the glucose level goes up, and then insulin brings it back down. Healthy, balanced diet is also going to include other types of food with other nutrients in, and these ones don't change glucose levels because they're breaking down to something else. If you want to know a bit more about carbohydrate food and other food, we do have a little leaflet on it. So we think about the type, because some types will break down into glucose more quickly than others. And we've got a target 1 hour after we eat in pregnancy. We don't want things to shoot up quickly and go high. We want a nice, slow, gentle rise in glucose levels. So an example of this is sort of thinking about glycemic index, or GI. We don't have to know these terms, but you might have heard of them. So something that's going to work to put glucose in the blood really quickly, an example would be some jelly, sweets, or cola. Great if you're hypo and you want your glucose to rise quickly. But if we're trying to eat in a way that helps manage glucose levels in pregnancy, we want to choose the slower carbs, or lower glycemic index. So we can think about some of the common carbs that some people might eat, and we want to choose the ones that are slower to put the glucose in the blood and allows the glucose to rise more gently. A lot of the time you might spot they've got more fibre in them. We also want to think about the amount. And for many women in pregnancy, this is an amount that we tend to see works well. But like lots of things, there's flexibility. And this is within the recommended portion size. But if you looked at that top tips leaflet, you'll see there is a range. You've got wiggle room. So the carbs might be slightly bigger. Let's say it looked like a third of a plate. What we would aim for, though, is that there is carbs at each meal and there's sufficient, because it is the body's main source of fuel. So we don't want carbohydrate intake to be too small. Just like we know if it's too big, that change in glucose after you eat will be more, and you've got a target that you're aiming for. So if the balance is, where do we see an amount of carbs where we can then see most women are finding it easier to get the target glucose? It might look like this. So if you carb count and you put in numbers to stuff, it's around 40 grams. If you don't carb count and you're thinking, how can I aim for that? And then sort of keep it similar. That could be an amount that's about the size of a fist, or it would fill about a quarter of the plate. If you want to put numbers to stuff, you can. And there's different ways you can get help with that. Food labels, another one. Internet. So we've thought about type, we've thought about amount, and now we're thinking about some extra little tools. And we're calling this one meal prep, because it's little things that you could do that will influence the glucose after you eat. So overnight oats, soaking them overnight, reheating cooked, chilled carbs, so like pasta or potatoes. This makes resistant starch, and this helps the glucose rise more gently. Beans, lentils, pulses, chucking it on salads, putting it into soups, maybe doing a 50-50 mix with meat or fish, beans and lentils. You've got soluble fibre, really slow release carbohydrate. And then there's some evidence around vinegar and like pickled vegetables like kimchi or sauerkraut. And again, this can influence how that glucose rises after you eat. Oh, question. Yeah.
I read this online. If you are, would that have an impact on the ratio that you need to use grams, or would it just be that it releases it slower but the same amount over a longer?
Yes, the second one. So it's really helpful to see what your experience is. It's an art, isn't it, rather than exact science. So keep that in mind. But yeah, wouldn't expect your insulin requirement to change. Would just expect to see that your glucose perhaps doesn't move up as much whilst the insulin's working after you eat. So it'll be more gentle, not go up as high.
That's not just internet talk.
That's it. It's not internet. It's not only the internet talking.
No, I wouldn't.
Mhm. And I think that's when it's you know, if you're curious, depending on what tool you might have access to and might use to check your glucose levels, you could have a little nosy, couldn't you, and start to look and see how these things influence your glucose levels. You might find sort of some things work better for you than others.
Just remind me again of how that overlaps.
Yeah, so that is basically making your porridge oats the night before, leaving it in the fridge, and the fact that you've done that changes it into resistant starch, and that will slow down the rise in your glucose after you eat. Whatever you choose, yeah. So in the pregnancy, if we think about oats, we're generally thinking breakfast, aren't we? And that can be a time of day when most of us are more resistant to insulin. Then chuck in the fact that your insulin resistance increases as your pregnancy progresses. So breakfast can be a tricky time. So some women might find early on that they can manage oats, but it'll probably need to be overnight, and you'll probably need to bump up the protein, fiber, and healthy fat, all in an effort to slow down the rise in your glucose. So a little tool that can help. Hi, it's up to you, Lindsay. That's a good question, you know. I don't know. Mm. Mm.
I think it's meant.
Is it?
If you do
I
read
should know that.
it,
Very stodgy. Look, you try it. Let me know.
yeah, you know, the plate, eating and they don't push it up straight away. It's just
Yeah, I know exactly what you
I
mean.
think that's doing that.
Say that again, sorry.
I think with yeah, and a lot of like yogurt that's kind of healthy.
Yeah, could be like a Greek yogurt. So you wouldn't be, by adding some Greek yogurt, let's say a couple of tablespoons even, you'll increase the fat and the protein, or just the protein, depending on the choice, but you won't increase the carbs significantly. Some people are using high protein yogurts as well. A good one.
I think it's like soft muesli in the morning. It's more vitamin component.
Yeah, that's true. You can add nuts and seeds, berries, give it an extra bit of, oh, and you could put a bit of cinnamon in, desiccated coconut, elevate it.
The Scottish people, there it goes. I think.
That is new to me. Oh. Yeah.
Pot was in 2 pots. Like morning. The water's in bottom. The oats in the top. Then you heat that up. Then in the morning you reheat.
Mm-hmm.
It's the first stage of the start it. With the children, isn't it? I don't know.
But there's one other thing about fat. That slows the emptying of the stomach.
It does, yeah.
That can be an element.
That brings me nicely onto my next point. Thank you. So we talk about pairing. So if we were to go back to that healthy, balanced meal, the image similar to what we've got up on the left-hand side there, but there was a lot more food items in it. In this example, we've got some protein from fish, we've got some carbohydrate from sweet potato, and we've got a salad. So if you think about that, we've got a mixture of different nutrients, and the carbs on that plate have got other food that are being eaten with it. And this helps slow down the rise in the glucose too. So we want to keep that in mind whenever we eat carbs, whether it's at a meal or a snack. So if you imagine double carb, jam on bread, that's going to push glucose in the blood much more quickly than if we add a different topping to the bread. We want to pair the carbs with protein and or healthy fat. So in this example, eggs and avocado. That's going to slow down the rise in glucose. The other thing they've thought about the type of carbs as well. They've gone for granary or seeded or sourdough, rye, pumpernickel. That's one, isn't it? We want to think about the timing. So aiming to eat 3 meals a day, spaced out across the day, will give you 3 opportunities to get lots of goodness from healthy, balanced meals. And spacing them out evenly across the day gives you glucose time to sort of move up and come back down before we eat again. It can help regulate your appetite, and eating in that sort of way where that meal's balanced can really help with feeling full as well. In the pregnancy, one of the other things we talk about is not eating too late. So one of the pieces of advice is to aim to have the last meal before 7:30. Then you've got a nice window then where the glucose is getting back down into target, ideally before bed. Once you're getting into bed in the target range, you're going to sleep. If you're getting a good 8 hours, maybe, that's like a third of your day. So that's like, that's a win, you know? That's a third of your time. So it can, let's be honest, it can be difficult to get tea that early, but it can be a change that some women focus on and they see a real benefit in it. Bit about timing, thinking about snacks. You can snack if you want to snack. And actually, one of the recommendations in the pregnancy, if we think about the amount of carbs we're describing at a meal, 40 grams, it's on the smaller side. So we want to make sure you're getting enough carbs. So it is recommended that you have a couple of snacks a day, small amounts of carbs. We want to pair the carbs with healthy fat or protein, and we want to choose the slow release carbs. So that could be like a bit of apple with peanut butter, bit of meat or fish on bread, oat cakes with a bit of cheese. We've got some rye crisp bread with avocado. It could be that you're still feeling hungry. Let's imagine it's the evening. You did manage to get your tea at 7 o'clock, but you're feeling peckish. You could go low or no carb. That protein food will help you feel full. You can mix and match. You could have a nice little dip, guacamole, salsa, get your veggies on the go. And these snacks won't change your glucose levels. We do have some leaflets, plenty of leaflets. So we've got one with low carb snack ideas. Nothing too fancy, but and some healthy carb snack ideas as well. So, keep an eye on the time. I'm going to start talking more quickly. Other things happen in pregnancy too, don't they? Things crop up. As Emma said, in the first trimester, you become more sensitive to insulin. You might be more prone to hypos. We'll support you with that. You might experience pregnancy sickness. We're going to support you with that as well. That might mean it's difficult to follow the dietary advice. Fine. There needs to be wiggle room, doesn't there? I did say that I would touch on the fact that, I've talked a lot. There's lots of ideas, lots of tools that you could have in your belt. And for a lot of people, this could be a whole lot of new information or a totally different way of eating. So it is helpful to know what you could aim for and think about where you want to put your focus. Choose something small and easy. It's more doable then. Then you do it and you feel good, don't you? Then you keep doing it and then you're all motivated and you might then start to think about another thing. Think about the thing you could do. Think about how you're going to do it and when. Give it a go. And, you know, don't beat yourself up if your plan doesn't go to plan. Were you a bit ambitious? Do you need to rein it in a bit? Make it easier. And don't forget that there could be lots of benefits you get from any change that you've been doing. So keep that in mind. And any progress that helps you get towards your goal, things are heading in the right direction. So, brief take-home messages from me is plan early. Think about if there's anything maybe that you've heard today that you thought, I'll give that a go. Start small, get help, and tell us ASAP when you get pregnant. Now, I'm just going to look at all this that I've got. Get ready. There's a whole tool from Tommy's website for planning, and it's tailored to you, it's individualized. So you get a little quiz, and then it says, well, what about this, that, this? That's good. If you smoke, you get a bit of help with that. You could plan ahead and learn more about managing your glucose levels. You could get help with moving more. Lots of dietary advice available. Now, these are all links that you could click on, so we're not clicking on them, are we? So we could get this in a different way, and then you'll know, or you could just have access to the links. We know that people might have, you know, think about insulin as like a medicine for diabetes. Well, what medicine might you have for your mental health? So it's okay to think that you might want support with your mental well-being, and that might be before pregnancy, during, it might be around pregnancy, it could be around something else. It was on carb counting. We've got videos. They're only like 2-3 minutes long. There's only 4 of them. It's a little refresher. There's different apps you can use. And although we might think, you know, I don't know if you can change your weight. Don't know. So maybe you could say, I might take the focus off the weight on the scales and just keep in mind these things that have come up today around being active or thinking a bit more about the food I eat. And that might lead to weight loss. So you might not put your focus here, but we do know that, you know, managing body weight can help sort of prepare you for pregnancy and help reduce insulin resistance. So it's just to let you know, there are services available that can support you with that in the longer term. We know long-term support is really helpful. That's it. Welcome.
One line thank you. One from Shirley Samuel.
I don't know what. So somebody I spoke to said they were pregnant early, or say 10 weeks, and
And they didn't think they were going to be checked for gestational diabetes until I thought this is a long way into the pregnancy. But if the people's, no, if you're having your urine checked at every check, it's likely to be spotted quickly. You couldn't. So, what point do you have to test for gestational diabetes?
Go on then.
So it depends. If you've got risk of gestational diabetes and you've never had gestational diabetes, you're offered screening at usually 25 to 28 weeks.
Yeah.
If you've had gestational diabetes in the previous, you're offered that screening. You're offered it at 12, 13, 14 weeks of pregnancy. If it's normal, you're offered it at 8 weeks. If you have glucose positive urine, then you're offered it at 8.
And so, say somebody is found that they truly have gestational diabetes, today's like a big education program really studying and women with type 2, I guess they'll get a little extra education, preconception in an ideal world.
In an ideal world.
So for the majority of centres that I'm aware of, you're usually plugged into something like a workshop. So, you know, in Jessup, they're doing 3 workshops a week, I think, where they kind of invite people who are tested positive for gestational diabetes, and they have some standard kind of education that they're given. They're taught how to check the glucose levels, and then after that, they'll see the clinic, and then their care is individualised. So it's kind of like you get an introduction, and then the care is individualised.
Right, sorry, can I ask a few questions? Is that okay?
Yeah.
I just thought I'd leave it. Yeah. So can I I'm just thinking in terms of, you know, supporting someone who has got diabetes. In terms of with meals and everything like that, is it better to, you know, when I, for instance, I cook, I'll be combining both the fats and the protein and the carbs all together. It's all one big mess. And then, you know, we then end up looking at, we weigh up the carbs beforehand, like, you know, something with rice, you weigh up the rice wholly, and then you just sort of weigh it by portion or something like that. Like, oh, that's a quarter portion.
Yeah.
So that's a quarter. So my question is, with regards to that, given how tightly controlled your diabetes has to be in pregnancy, do you think it's probably better that you just keep the carbs separate so that you can just count them a lot more accurately when you're having food?
Great question. I mean, what does your partner think?
And rice,
Yeah.
you know, like you make a pesto pasta and it's all combined together. So
Yeah.
the of the chicken and the
So ideally, to carb count accurately, you do need to, like, for example, if you were weighing it, you'd need to just weigh the carbs, wouldn't you?
Yeah.
So just the pasta or the rice. And then once you've sort of chosen the amount that you're eating and you know the carbs, then you chuck everything else in and mix it up and everything. That makes it more accurate. And if you weren't weighing it, and let's say it was a meal, and you happen to find that meal, for example, in Carbs and Cal's book or RAP, you know, you could gauge it in a different way, couldn't you? But it won't be as accurate. And in the pregnancy, there's a lot to think about, but counting the carbs accurately can make a big difference to your glucose levels.
That's that was going to lead on to the next thing, which was, I mean, basically, are you saying that controlling what you're eating, like in terms of cooking your own meals, and you're not like getting takeouts and all that kind of stuff, like stuff where you can sort of control the amount of carbs. Would you be recommended that more?
It's an ideal world, yeah. I mean, we don't live in an ideal world, do we? And you know, it's unreasonable for, I'm not going to sit here and say you're never having a takeaway in the 9 months that you're pregnant. But what we do see is it can make it difficult to manage your glucose levels. But, you know, we do have to appreciate that the glucose targets, for example, if you were looking at time in the pregnancy target range, we want over 70%. So, you know, it's okay for the glucose to move out of that target range sometimes. It's not about 100% perfect. But
I always, going back to the earlier point, I always find it's easier to weigh in the first place. 2 reasons. One is, if you start to weigh later on, the food's going to go cold. But it's easier if you're weighing the ingredients.
the dry ingredient,
And
yeah.
secondly, some that will absorb more water. So if we cook it one day, it's got
Excellent
more
point.
water.
So that's another option actually. You could weigh the dry or raw pasta raw rice.
Yeah, we tend
And
to
what-
weigh it dry.
Okay, yeah.
We weigh up our rice.
And then you can,
I go whole, yeah, rice is already cooked right then.
yeah, that sounds really helpful, those steps that you're taking.
And then this one's for you.
Okay.
Sorry. It's for Josh. Is protection from taking aspirin. Would you be routinely recommending that as well?
What do you mean, like having indigestion? No, but it depends. So the majority of women do obviously they look at the risks and they, you know, are the risks of kind of, you know, GI bleeds and stuff that you would have. You can sometimes do that. No, we haven't seen any increase in this. If you have esophageal reflux disease, and that can be really troublesome, and we can use it, but we don't give blankets. Yeah, coffee.
It just means a lot more cooking. That's all. It's a good thing that she likes my cooking. That's the
And practice makes perfect, doesn't it? Getting into that routine can speed things up a little bit. And some people like the carb portion list because it's got some handy measures like cup measures. So you wouldn't weigh it. You'd fill, for example, a certain cup size and read the carb info. Have you got Carbs and Cals app? And have you paid for it so you can tap on the weight and change the weight? Excellent, yeah. Yeah. I haven't got shares, but it is good, isn't it? I wish I did. But like, for example, if you had it say a number crunching and doing the maths to work out the carbs in the food, with the app, you just tap on the weight, change it to the weight of your portion, work out the carbs for you. You've been withholding information from him.
But I think as well, if you eat something and you've worked out, I don't know, say that's 35 grams of carbs, and then your blood sugar goes up, before you add that again, you really bring it down, wouldn't you?
Yeah.
I know you'd like pan it immediately there and then, like go down there. You can review it.
Yeah, that's.
You're aiming for 40 grams per meal.
You know, thereabouts, yeah. Now, that's helpful for a lot of women in pregnancy. You might not need to limit it so much before. And don't forget, the target is broader away from pregnancy. So it's still looking at optimal glucose levels. And, you know, you might find that if I eat 50 grams of carbs, I'm still getting the optimal glucose levels. Yeah, something to try, absolutely. But and then it's wiggle room exists.
Somebody said, is it possible to slide?
I'm sure it is. I just please just look at it and make sure it's not stolen things.
Yeah, that'll be possible. And then they can click on all the links that I've put in. Countless links.
Got the slides. Send them through.
Emma just wanted to.
Just need to just double check on.
I'll double check as well.